So today we have a seminar on ABG. So how to manage, how to navigate an ABG, and also what you can treat and what you need to refer from your bond senders. So this is presented by Dr. Ria Robin, who has completed her MBBS from HIMS Hassan and currently works as a junior resident in the Department of Critical Care Medicine in St. John's Hospital. And also is moderated by our own Dr. Prem Prakrit, who has completed his MBBS from Trivandrum Medical College and MD Medicine from Mysore Medical College, and is currently in his final year of DM Critical Care Medicine at St. John's Hospital. I welcome both Dr. Prem and Dr. Ria to this session. I will hand over to them so that they can manage this session by themselves. I'll be telling you this session is supposed to be a total of 1 hour, in which about 20 to 30 minutes will be the presentation, and then you guys can ask questions after that. If there's any questions, you can put it in the chat box or in the WhatsApp discussion group, where we would be able to answer your queries. Thank you. Over to
Thank you.
Ria.
Okay, thanks, Danny. So, hi everyone, I'm Dr. Ria Robin. Today I'll be presenting how to navigate an ABG. So before I start this session, I request all of you to keep a pen and paper in hand, because we'll be solving some problems towards the end as well. Okay. So yeah, so this session is basically a simplified approach to an ABG. So when you get an ABG in hand, what are you supposed to be doing first? So I won't be dealing with the pathophysiology and all of that. That is left to you, your interest. You can read about it and all of that. But once you get an ABG in hand in your bond center, what will be the first thing that you should be doing? Okay. So moving on. So today we'll be playing around with these values: pH, PCO2, and bicarb. So these three values are what we'll be taking into reference. So what is exactly a normal pH? So normal pH, we will be taking it as 7.4. So the range will be from 7.35 to 7.45. And PCO2 is nothing but the partial pressure of carbon dioxide in the blood. So basically, it's a dissolved carbon dioxide that is present in your blood. So what is the normal range? That is 40 millimeter mercury. And the next thing is bicarb. That is 24 milliequivalents per liter. So we'll be dealing with these three values in the entire session. So these are the normal values. So please keep this in mind, because we'll be getting back to these values over and over again during the entire session. So now when there are alterations within these values, this will result in pathological states known as respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Okay. So how do you go about interpreting an ABG? So you get an ABG in your hand. The first thing that you should be seeing is the pH. So if your pH is, say, less than 7.35, we would call that as acidemia. And if it's more than 7.45, you call it as alkalemia. So first step done, you've seen what your pH is. Next, right below that, you'll be checking for your partial pressure of carbon dioxide, otherwise your PCO2. So the hack over here is, if the PCO2 and the pH, they move in the same direction, it's most likely a metabolic component. And if the PCO2 and the pH, they move in the opposite direction, it is a respiratory component. Next step is, you've identified whether it's respiratory or it's metabolic. Then you go about looking for the concept of compensation. So what exactly is compensation? So in our body, basically, the respiratory and the metabolic systems are linked. So so now, as you know, the normal pH is basically 7.4. So why is it called as normal pH? Because all the enzymes in our body will function at that pH. So what happens is, if there's an issue in your metabolic component, like say bicarb is reducing or something, similarly, your PCO2 will basically reduce as well, to bring about a change, normalizing the pH. So let's take metabolic acidosis, for instance. So in metabolic acidosis, the primary disturbance is basically the bicarb is falling to counter the H+ ions, right? So there's pH drop. So what happens? The PCO2 also will fall down, so that the pH comes back to normal of 7.4. So there's basically a metabolic and respiratory interlink that's happening to bring your pH to a level of 7.4. Now let's take respiratory acidosis. for instance, say a patient has carbon dioxide retention happening in his system. So the body recognizes that it's in a state of acidosis. It has to bring the pH to 7.4. So what happens is the bicarb level in the blood starts increasing. Basically, there's reduced secretion or excretion of bicarb in the kidney. So as a result, the bicarb will increase to buffer the PCO2. And as a result, they try to bring the pH to a state of 7.4. So if you can see the table, basically you can see that in metabolic acidosis, what happens, the pH drops, the primary disturbance is reduction in bicarb. So the secondary response will be the drop in PCO2, bringing to 7.4. Now moving on to alkalosis, if you can see the pH, the arrow is pointing up. So basically indicating that it's alkalosis. So the primary disturbance over here is there's an increase in bicarb. So what does the body try to do? It tries to increase the PCO2 levels so that the amount of acid will basically help in neutralizing this alkali, trying to bring the pH to 7.4. It's a similar phenomenon in both respiratory acidosis and alkalosis as well. Okay, moving on. So let's take an example. Now you come across a patient, his pH is say near 7.4, okay? But his PCO2 levels are increased. I told you the normal PCO2 we'll be taking today is 40. So his PCO2 is 45. And as a result, the bicarb is also increased. So you see, basically, let's take pH of less than 7.4. He has acidemia. Okay, that's the primary problem. And there's an increased PCO2. So indicates that the patient is basically in a state of respiratory acidosis. So what does the body do to counter this? It will basically increase the bicarb levels. So the normal bicarb today is 24. So in this patient, the bicarb was 26. So because of that, the pH is brought towards almost normality in this person. Okay, and next example for compensation will be this. So here the pH was more than 7.4. And it was noticed that this patient's bicarb was more than 26. And it was also found that the PaCO2 of this patient was around more than 45. So here, again, the patient seems to be in a state of alkalemia, and the bicarb is also on the higher side, indicating that it's metabolic alkalosis. Okay, so then thus as a result of compensation, the PCO2 is increasing in this patient. That's why it is around 45. And thus the pH is brought back towards normality. So these are basically some compensatory formulas which basically gives you a prediction of compensation. You can note this down or you can take a screenshot of this because this will come in handy. I can also put this in the group if you like. Okay, so I'll be going about each formula here. So in metabolic acidosis, what happens? In metabolic acidosis, the component is there's a drop in bicarb, right? So the formula is also called as Winter's formula, where your expected PaCO2 fall should be equal to 1.5 into bicarb plus 8 plus or minus 2. This is nothing but Winter's formula. Okay, so with this, the value that you get from this should correspond to the PaCO2 in your ABG. So if it's not there, it indicates that the compensation has not occurred. So I'll be giving you further examples on compensation as well. You can just note this down. Then metabolic alkalosis, there is a simple formula where PaCO2 is equal to bicarb plus 15. So in respiratory alkalosis, it can be acute or chronic. So here, bicarb should drop by 2 milliequivalents per liter for every 10 millimeter mercury drop in PaCO2. Whereas in chronic patients, the bicarb should be dropping by 4 milliequivalents per liter for every 10 millimeter mercury drop in PaCO2. Whereas in respiratory acidosis, bicarb will increase by 1 milliequivalent per liter for every 10 millimeter rise in PaCO2. Whereas in chronic patients, bicarb will increase by 4 milliequivalents per liter for every 10 millimeter mercury in PaCO2. I don't expect you guys to remember all of this. Nobody remembers it. It's okay. Just keep a note of this. I'll share it as well. It'll come in handy. But it's quite, you actually need to see whether there's compensation or not that has occurred. So just keep this in mind. Okay, moving on. So coming to the concept of anion gap. So you'll be calculating this anion gap in a case of metabolic acidosis. So if you identified a metabolic acidosis in your ABG, you'll have to find out what is causing it. So anion gap comes in handy. So what exactly is anion gap? It's the difference between the charges of plasma anions and cations calculated from the difference between the routinely measured concentration of serum cations and anions. So the simplified formula for this is nothing but sodium plus potassium minus chloride plus bicarb. But since potassium is more of an intracellular cation, usually in practice, it is basically sodium minus chloride plus bicarb. So in your ABGs, if you find that you have metabolic acidosis, the next thing you should do is calculate anion gap. So normal values are from 6 to 12 millimoles per liter. So what happens is albumin is an anion. So in a patient with hypoalbuminemia, you might come across such patients. Then what happens is if the albumin levels are low, you might get a false normal anion gap. So that's why it's essential that you should calculate something called an adjusted anion gap. So please make a note of this formula as well. Adjusted anion gap is equal to anion gap plus 2.4 into 4 minus the albumin value that you have in hand. Okay. So moving on. So now we've identified. So metabolic acidosis can be normal anion gap metabolic acidosis or high anion gap metabolic acidosis. So this is basically an image to show what a normal anion gap is. So in your body, there are something called measured and unmeasured cations and anions. So if you see in the yellow column, you have sodium and the unmeasured cations. And in the blue one, you have chloride, bicarb, and the unmeasured anions. So this anion gap is nothing but the unmeasured anions that are present. So this is nothing but a normal anion gap. Moving on to what is called a high anion gap. So if you've noticed between the first and the second, the anion gap has increased, right? Because the unmeasured anions are increasing. So basically what happens is new unmeasured anions are added, like say in the case of lactic acidosis, lactates will come in, or ketosis, ketones will come in. So that is causing the gap to increase. That's why it's called as high anion gap metabolic acidosis. So there will be a corresponding fall in bicarb as well, because as you know, the system of buffers. So when there's an acid to neutralize it, a bicarb will also come in. So then since there are unmeasured anions coming in, the bicarb will try to buffer. So there's simultaneous drop happening here as well as the addition of the unmeasured anions, causing the gap to increase. So this is nothing but high anion gap metabolic acidosis. So now you've identified that it could be high anion gap metabolic acidosis. So these 4 differentials should come in your mind at that point of time. What could be? We have a lot of mnemonics like mud piles and all of that, but these 4 should come in your head when you see that you have a high anion gap metabolic acidosis in your ABG. So one is lactic acidosis. So this lactic acidosis in the ABG, you can actually identify by seeing the lactate values. Then ketoacidosis. So now if a patient comes with a history of suggestive that they have type 1 DM or anything of that sort, ketoacidosis is one such differential that can come in your head. Then renal failure. So renal failure, you can actually measure this through your GFR or your RFTs. That will give you an idea whether the patient is in renal failure or not, or any clinical signs of renal failure, whether he's in, or any reduced urine output. So these 3 differentials should come in your mind, the first things. After that, if it doesn't fit into any of this, that's when you can think about all these toxic alcohols like ethylene glycol and all that. So that's when we come across the concept of osmolar gap. So osmolar gap is nothing but the gap between the calculated serum osmolarity and the lab measurement of serum osmolarity. So if you have a high osmolar gap more than 10, this will suggest that there's something called a presence of toxic alcohols like methanol or ethylene glycol. The formula is calculated osmolarity is equal to 2 into sodium plus glucose plus urea. So now we've identified that it could be HAGMA. So we do have a concept called as delta ratio. So delta ratio is to see if it's just HAGMA or if there's a coexisting normal anion gap metabolic acidosis or respiratory or metabolic alkalosis. So delta ratio is nothing but the increase in anion gap by the decrease in bicarb. So the formula is Ag minus 12 by 24 minus bicarb. So you can note this down as well. So now after doing all of these calculations, you get your anion gap by calculating the formula minus 12. and you have your bicarb level in your ABG as well. Okay, so this is how you have to interpret the values. If the values say less than 0.4, it is NAGMA. If it's 0.4 to 0.8, it is NAGMA plus HAGMA. If it's 0.8 to 2, it's HAGMA, and if it's 2, it's high anion gap metabolic acidosis with a coexisting metabolic alkalosis. So the whole idea behind this is we should not miss if there's a NAGMA or if there's a coexisting metabolic alkalosis as well, if there's a HAGMA. Okay. So to sum it all, the first thing that you should be doing is check the pH, whether it's less than 7.35 or more than 7.45. So that will give you an idea if it's an acidemia or an alkalemia. Next, check for the PCO2 levels. So if the PCO2 and pH move in the same direction, it's metabolic. If it's in the opposite direction, it's respiratory. Then check for compensation. Now, in the case of a metabolic acidosis, you will check for anion gap, whether it's a HAGMA or a NAGMA, followed by a delta ratio to see if it's just a pure HAGMA or if there's a coexisting NAGMA or an alkalosis. So after this, at the end, you have to find out the etiology, like what exactly is happening. So I'll be moving on with the cases. So I hope everyone has their pen and paper ready. So Mr. John, 40. So this is basically a discussion which will be including Prem sir, the moderator as well. So you can keep your mics on if you have any doubts till now. Okay, so we'll move on with this case and then we'll go about it. So Mr. John, 46-year-old, who's a known case of CKD, T2DM and hypertension. He presented to the ER with complaints of fever, abdominal pain, altered sensorium and reduced urine outputs in 2 days. On examination, he was found to be tachycardic and hypotensive and febrile. So they suspected that he was in sepsis and septic shock. So what does the ABG basically indicate? So the pH is 7.138. PCO2 is 33.9, sodium is 138 millimoles per liter, chloride is 111 millimoles per liter, bicarb level is 12, and lactate is 18. Okay, so any one of you can interpret this ABG. So I would like any one of you to interpret the ABG and let me know how to go about this. Daniel, hello?
Yeah. Yes.
Yeah. Is anyone up for discussion?
Guys, would you like to answer? Like, if you want to put it in the discussion group, your answers, I can forward that to the presentation at the moment, or if you want to put it in the chat box, you can put the results there. Or if you would like to speak, I can do that too. Yep, Nathaniel, do you want to say something?
Hi, this is high anion gap metabolic acidosis, really because of lactic acidosis.
Okay, why do you say it's a high anion gap metabolic acidosis?
Because there's the fall in bicarb is more than, I mean, this I've not really calculated it in because I didn't have a pen and paper, but the fall in the bicarb is more than the PCO2, and there's basically bicarb is low and the pH also is low, so it's probably acidosis secondary to a fall in the bicarb levels. And I mean, that's all I can say, because I've not really calculated it. I don't have a pen. So
okay, so has anyone calculated it? Is anyone else up for it? So Daniel, is anyone up? Anyone else?
I can't see anybody else who has raised a hand.
Okay, so should I move it with the solution?
Yeah, you can go ahead if there's nobody who's.
Okay. Yeah. So step 1, basically identify what the pH was. So the pH was 7.13, indicative of acidosis. So since both the pH and the PCO2 were dropping, so it's basically suggestive that they were in the same direction, so metabolic. And then next you check for compensation. So the formula is basically PaCO2 is 1.5 into bicarb plus 8 plus or minus 2. So I got 28. But the PCO2 was 33.9. So suggestive that there was no compensation that occurred. So we figure out that it's metabolic acidosis, so anion gap. So the anion gap in this patient, as per the formula, is 15, which is suggestive of Hagma. And then we calculated the adjusted anion gap because this patient's albumin was 1.3. So he was hypoalbinemic. So the anion gap was 21.75. So after that, we calculated the delta ratio, which gave us a value of 0.8. So 0.8 was suggestive of pure Hagma with no coexisting Nagma or metabolic alkalosis. So yes, Nathaniel, you were right. It was high anion gap metabolic acidosis. So any doubts so far?
Guys, if you have any doubts, you can put it in the chats or in the WhatsApp group. Or you can raise your hand or you can ask a question now. Ria, if there's any doubts, we can always discuss it after the presentation.
Yeah. Cool. Okay, no, the thing is, we'll be going simultaneously with the case discussion as well. So if you have any doubts at this point of time also, you can raise. Okay. Yeah, so moving on. Yeah, Mr. Shaw, 60 years old, known case of COPD presented to the ER with history of breathlessness. What is the ABG suggestive of? So here the pH is 7.269, PCO2 is 69.9 millimeters mercury, PO2 is 93 millimeters mercury, sodium is 136, chloride is 1.5, and bicarb is 24. Please interpret the ABG. So Daniel, anyone up for it?
I don't see anybody in the groups or in the chat. Probably you need to give them some time to do some calculations too.
Okay, cool. Just let me know when I can go ahead.
Does anyone want to volunteer the answer? Ria, it seems like nobody has volunteered any answers anywhere. So you want to go ahead with the...
Yeah, go ahead.
Yeah.
Okay. Okay. So okay. So moving on. So again, stepwise approach. So the first.
Yep. Atul has raised his hand. Let's.
Okay. Cool.
Atul, you wanna say anything? You can speak up.
Hello. Can you hear me?
Yep.
Yeah.
Yeah. So I mean, using the stepwise approach. First step is check for acidosis. So first of all, pH is 7.26, so it's acidosis, and then we look at PCO2 and bicarb. So clearly PCO2 is on the higher side, around 70. So it goes with respiratory acidosis, and it is
Yes.
not compensated.
Okay. So what was your expected compensation? Did you happen to calculate by any chance?
No, I couldn't calculate.
Yeah, not okay, fine. Let's go ahead. Okay.
Yeah.
Yeah.
Okay.
So, okay. Okay. So, step one was yes, as Atul had told rightly, it was acidosis because the pH was 7.269. And since the PCO2 was increasing and the pH was falling, indicative of respiratory. And the compensation, it basically, if you go back to the formula, of compensation in respiratory acidosis. So the bicarb should increase by 1 for every 10 millimeter rise in PaCO2. So here the expected compensation was supposed to be 27, but unfortunately it was only 24 in this patient. So it basically indicates that it's not compensated. And even the pH per se gives you an idea at 7.26, it's not 7.4. So there's no compensation happening. So it's not compensated. So Atul, as rightly said, it was respiratory acidosis.
Yes. Yeah. Nathaniel wants to say, ask a question or ask a query. You can ask. Nathaniel.
Yes,
Is that
please.
different with
Sorry?
respect to what about the chronic component? The fact that you've got COPD. Are you taking
Yeah.
for
So there are two formulas basically for that. Yeah, you have for chronic, it's basically by 4 for every 10 millimeter rise in PaCO2.
yeah? So this patient already has COPD, right?
Yep.
So is there a possibility that you should? How do you go about it? Do you do an acute formula, or would you use the chronic as well?
You would use the chronic, so it should basically increase. So 20, yeah. So, yeah. So for 30, his should have gone up by 4. So I think 3. I use the acute formula here, but ideally you can use the chronic formula as well. This is just for an explanation's sake. That's it. So if so ever I'd used the chronic formula, then his PCO2 bicarb would be somewhere in the 30s. Again, not compensated. And I think the first pH itself will give you an idea. Like it's not 7.4 or anywhere near that figure. So it's unlikely that he is compensated. I hope I've answered your query.
Thank you.
Okay. Moving on. So case 3. Yeah. So here, Mr. George, 50 years old, presented to ER with history of vomiting and diarrhea since 3 days. So on examination, pulse was found to be 98 beats per minute with low volume. BP was 90 by 60. Saturation was 96% in room air. And what does this ABG indicate? So here in this, the pH was 7.50. PCO2 is 42 millimeter mercury. PO2 is 87. Sodium is 145. Chloride is 105. And bicarb is 32 millimoles per liter. So anyone up for it? Please let me know.
Is anybody ready with the answer? Yes, Atul has raised his hand. Atul, would you like to speak?
Hello. Again, going with the same approach, first step is checking the pH. So pH is 7.5, which suggests alkalosis. Then bicarb is 32, which is increased. So it suggests metabolic alkalosis, and PCO2 is 42. So what we expect according to the formula is bicarb plus 15. So it is
Yes.
not, it's not compensated. So it should have been 32 plus 15, 47. It is only 42.
Okay.
So it is not compensated.
Yes. So yeah, lovely. So basically, yeah, stepwise approach. It was alkalosis, and then you check for compensation. It was basically bicarb plus 15. So 32 plus 15, 47. So as a result, it's not compensated because our actual PCO2 was only 42. And again, if it was compensated, the pH should be say around 7.4, 7.4, but it's 7.5. That itself is suggestive that it's not compensated. Okay. So moving on. This is the last. So it's basically metabolic alkalosis with secondary respiratory acidosis. So if you notice, the pH in this was PCO2 is 42. So there's a slight component of respiratory acidosis as well that was setting in. Okay. This is the last case. So Mrs. Kumar, 65 years old, presented to the ER with persistent vomiting and tiredness since Monday. So what does the ABG indicate? So pH here is 7.47, PCO2 is 45 millimeters of mercury, PO2 is 87, sodium is 145, chloride is 105, and bicarb is 29 millimoles per liter. So please interpret what the ABG.
Has anybody come with an answer? You can raise your hand or answer in the group or on the chat. I don't see anybody volunteering with an answer. Do you want to move
Yeah,
forward?
I'll go ahead. So last one for the day. Yeah. So again, stepwise approach. pH was here was 7.47. So slightly on the alkalotic side. So we'll take it as alkalosis. Again, so the PCO2 was 45. And again, so when the pH and PCO2 move in the same direction, it's indicative of a metabolic component. So the compensation here is for every increase in bicarb, what is the expected increase in PaCO2? So the bicarb plus 15 formula. So the bicarb in this patient was 29 millimoles per liter, added 15, 44. And the PCO2 was 45. So pretty much compensated. So this was nothing but metabolic alkalosis with secondary respiratory acidosis present, but there is compensation occurring. So that's why the pH was around 7.47. So the take-home message at the end of the day is treat the patient, not the ABG. Thank you. So yeah, we're up for discussion. So any doubts?
Guys, if you have any doubts, you can ask now. I don't see many people here, so only like 2 or 3 of you all. If you have any doubts, you can directly ask. The moderator, Dr. Prem, is with Riya, so he can also answer any of your more complicated questions. Sorry, it looks like there are not many questions that's coming up. So I'm guessing we can end this session here. Thanks, Riya, and thanks, Dr. Prem, for this wonderful session. It was very informative. I'm sure these questions would have helped our bonders, and also it was quite informative, going stepwise, understanding the ABG and about treating the patient and not the ABG. It was all really very well done. It was a very good session. One more announcement is that I have put a link to the feedback form. So this would help us, the organizers and people taking the session, understand what you're lacking and what we can do well. Also, it will give you a chance to give us more ideas for next sessions. And thanks one and all for attending this session. I'll be ending the recording now. Thank you.
Thanks, Dan.